Well, thank you, Mark, for the very kind introduction and for the invitation to be with you today. What I'm going to do is not give you a list of new drugs, because that would be really dull. What I'm going to try and do is give you the background behind how we develop new chemotherapy for children, looking at where we come from, what we're doing now, and the challenges for the future. So, childhood cancer is mercifully rare. Only 1 in 600 children will develop any form of malignancy by the time they're 15. And that equates to about 1,600 new cases in the UK per annum. Only 1 in 200 cases of cancer in general occur in childhood, but it's important because it's the second commonest cause of death in childhood. Only accidents claim more lives. Now, it's really important to realise that it's children with cancer, not cancer in children. Children are absolutely not small adults. The disease strikes at a time when they're growing and developing, so the late effects of the treatment are really significant. And if you're an 85-year-old with prostate cancer, then you've got the option of just containing that disease, because you may well die of something else before you die of that. That isn't the case in childhood malignancy. If you've got a child with cancer, then that is their big headline risk. And to extend that child's life, you've got to try and cure that tumour. Children's cancers are different from those in adults. All the big adult cancers, breast, colon, lung, just don't occur in the same way in childhood. And multidisciplinary paediatric skills are really essential. In the bad old days, and the bad old days was when I was born, 1958, it was almost universally fatal. It was poorly recognised and symptoms were difficult to manage and control. Now, we've got over 70% of children diagnosed with cancer are cured, even when they present in extremis, like this girl did here, and here she is just a few months later. Results are improving by about 10% per decade. And we're aware now that symptom control and quality of life issues are as important as just simple cure rates. So if you look at childhood cancer, 25% of them are in the brain or the spine. And it's not just one diagnosis for brain tumours. There are many diagnoses. Medulloblastoma, PNET, 23% of cases. The low-grade astrocytoma, about 37%. But look at these, choroplexus tumours, 0.5%. So if you look at it, 1 in 600 children get cancer. 1 in 4 of those cancers are brain tumours, that's 1 in 2,400. And 0.5% of those are choroplexus tumours. So 1 in 480,000 children will get a choroplexus tumour. And that's really fantastic, because it's great that it's so rare. We wouldn't want it to be more common, but it makes doing studies on these tumours really very difficult, because you don't get the numbers. The survival varies according to tumour type, with all types of tumour having a 5-year survival of around 5%, but it goes from the almost completely curable to the almost completely incurable. And many of these children are really very young, where their brains really are developing, and they're very sensitive to therapy. If you look at survival according to age, well, you see the inverse of what you do in adults. In adults, the younger you are, the better you do. In childhood, the younger you are, the worse you do, especially if you're under 2. Now, why is that? Do they get more aggressive tumours? Well, perhaps. Do they present later? Well, perhaps. But the big reason that the under 2-year-olds historically have done worse is that one of the most effective forms of treatment for brain tumours, radiotherapy, which Yen will come on to next, simply hasn't been offered to this age group, and therefore they haven't done as well. And it hasn't been offered because parents and doctors together have made those difficult decisions about looking at the quality of life of the child in the future versus the chances of cure. If you look at, this is a slide taken from the up until 2000, and if you look at it, chemotherapy had a relatively small role in the management of tumours, whereas in brain tumours, where it was absolutely de rigueur in the others. Now, why was that? Well, neuro-oncology has been the Cinderella of cancer therapy. Historically, there's fragmentation of surgery, of service delivery. You saw a surgeon, you saw a radiotherapist, you saw an endocrinologist. We didn't work together. there were difficulties in tissue collection, there were problems making the right diagnosis, and it was very difficult to judge the response to therapy non-invasively. We've come on fantastically. The original work, this is 1982, this is when I finished training, and you had people like Jonathan Bloom from the Marsden doing excellent work reporting 10 years of his experience with all tumours in one hospital. Now, it's a brilliant start to the way of looking at things, but that's like reporting all abdominal tumours in one hospital. It's not really going to move you along. That's where we came from in a not too distant past. Let's see what's changed it and where we are now. Well, we've had more than 2 decades of an improved ability to perform clinical trials. As you've heard from Connor, improved surgical and anaesthetic techniques allow us to make a histological diagnosis in most cases. We now have internationally agreed classifications, so we all agree on what we're treating. Improved neuroimaging is allowing us to stage the disease and measure response to therapy. We're all collaborating internationally to try and work out the best treatments, and we're looking at the quality of life of the child as well. So let's look at how X-rays or neuroradiology helps an oncologist. Well, it helps make a diagnosis, it helps us stage the tumour, and it allows us to assess response as well as diagnose a recurrence. Again, when I started, people used to do plain X-rays or pneumoencephalograms. That was in 1977. And we've gone from that to the absolutely perfect anatomical detail of an MRI scan within a couple of decades. And if you walk into any good radiology department now, it looks like the bridge of the Starship Enterprise with all of these various methodologies, and they continue to improve. Connor's intraoperative MRI isn't on there, that probably should be. So sometimes radiology can make a diagnosis without us having to have a biopsy. The most awful picture in paediatric oncology is a brainstem glioma, and that's diagnosed here, and here's an optic tract tumour there. But much more often, as in this big tumour, it's a mixture of the radiology and the pathology that helps us make the diagnosis. And once we get the specimen, there's now an internationally agreed and continually revised way of looking at the tumours. So what we've ended up with is this concept of a diagnosis as not just a label, but the data set that you need to do a job. Having the right diagnosis enables you to plan therapy, it allows you to give a good prognosis for good or ill, and it allows you entry onto a scientific or a clinical research protocol. So when we're doing studies, and I report my cases, or we report our cases from the UK, the people in Canada or the people in America can believe us because we're all talking the same language. The diagnoses aren't static. They change with time. We work out different types of tumour. We separate them out, and we subclassify them. Also, we're understanding much more about what goes on in the molecular clockwork of tumour cells, what makes them behave as they do, and that is changing our understanding of what a tumour really is. So if you look, with all these tools, we can now do really good trials. This one closed about 18 months ago, where we were doing a comparison of 2 different radiation techniques in a tightly defined population of standard risk medulloblastoma. We knew what the population was, everything was centrally reviewed, it was a multinational study, and biological and late effects questions were asked. Now that is a completely light years away from Jonathan Bloom's original work in 1982. And it was only the ability of organisations like the CCLG in the past and now with the NCRI that Amos will tell you about, that gives us the opportunity to do these studies nationally and internationally. The difficulty is that the better we understand the tumours, the more we subdivide them, the smaller number of patients there are in each group to study. So when we started treating these under 2-year-old children, everybody treated all the children on exactly the same protocol. Those protocols varied depending on what they, from nation to nation, but every child with a malignant brain tumour got an identical chemotherapy protocol for that country. And in the UK, we aim to delay radiotherapy for all and omit radiation for patients who are in complete remission at the end of chemo. Not surprisingly, how you did, what you had, determined how you did. For a non-metastatic, complete resected ependymoma, fantastic. For medulloblastoma, bad. For non-medulloblastoma PNET, terrible. Now, you clearly can't continue to use the same treatment for these three groups of patients. And if you add in all the other features that we were finding about the tumours, all of which impacted on survival, you end up dividing the group from all diagnoses into these tiny little groups of patients, where there's literally 4 or 5 patients like this in the UK per annum. So how can we do studies like on these tiny subgroups? These the small groups each have different outcomes, very small numbers of patients. There's no chance of running a big randomized studies with any sorts of power, and even if we do them internationally. And that's where we're relying on our clever statisticians to start looking at completely different models of how we run studies in the future. Now, so far we've talked about medulloblastoma and how we've almost capitalized on success. But there are tumours, such as high-grade astrocytoma, where if you look at how we're doing, we have made no progress for 40 years. None. This is a survival curve showing we're no better in 89 to 93 than we were in the 70s. It looks as if we're worse, actually. We're just better at diagnosing the high-grade astros and separating them from the more curable low-grade ones. There is a subset of children whose diseases are simply not responsive to chemotherapy and simply not responsive in a curable sense to radiotherapy either. And what do we do? Well, what we have the ability to do now is understand what messages the cancer cell is getting to tell it to behave in the way that it's behaving. And this isn't just stamp collecting, it's actually giving us vital clues as to how the tumour is working. So this is a normal cell, and it's got a message here saying grow when told, and always check that the growth is appropriate, and the right amount of growth happens in the normal cell. Sometimes that message is amplified. There are too many copies of the message, neuroblastoma, medulloblastoma, for example, and the cell grows too quickly. Sometimes the message is scrambled. Grow when told, always check, and has become always grow, check when told, and you get too much. And that's the way that lymphomas and some sarcomas work. Now, so far we've looked at too much growth message, but also within each cell of our body, we've got something that stops us getting cancer. And imagine that gene is a soldier protecting here your eye against a tumour called retinoblastoma. You've got a functional gene from your mum, and you've got a functional gene from your dad, and even if you lose one, you've still got a soldier to stop cancer getting you. But when you haven't got any functional genes, then your eye can go on and get cancer. So you've got growth-promoting genes, and you've got genes that stop you getting tumours. And together, they work in this very complicated schema, the details of which aren't important, to give you just the right amount of growth. So if you fall over and scrape your skin, it'll regrow really quickly, and then it'll stop. And that's what it should do. Whereas in cancer cells, that growth is now abnormal. Now, does this give us any idea of how we can start interfering with that growth? Well, there are already now novel molecular therapies which aim to block signals from overactive oncogenes that force tumours to grow, that block tumours from getting a blood supply, that block tumour invasion, that promote suicide of tumour cells. All of these things may not result in immediate shrinkage of the tumour. If you stop a tumour getting more of a blood supply, it won't continue to grow, but it won't go away. Now, do we have tools to measure what we're doing, though? Well, if you were trying to plan a rational molecular therapy, you'd have to do a biopsy to confirm that the molecular target was there. You'd have to show that the drug gets to the target, show that the drug blocks the target, show that it has the desired effect, and investigate the response. Now, in leukemia, that's dead easy. You do a blood test. If you've got a tumour that's buried in the centre of a child's brain, that's really not practical. And so what we have to do is use surrogates for response. measure tumour vascularity on MRI, measure tumour metabolism on MRS or PET, or look for changes in tumour aggressiveness using other methodologies. Also, blocking something, if you imagine the sort of the signal to grow as almost like being a river, and you want to block that river, that force of water going forward, well, you might be able to do that effectively, but we all know that even putting a dam in one bit of a river means that you can get backflow around the edges. So the assumption is always going to be that these new molecular therapies are not going to be a one-shot deal. They're very unlikely that one single drug is going to be able to stop the abnormal growth sort of signal forever. And then you're going to end up needing multiple dams over a period of time, and often for a very long period of time, to make sure that the child remains with a tumour that is not growing. If you also, another type of therapy that we need to just touch on, everybody likes the idea of the body fighting the tumour itself. An idea that the immune system will recognise a tumour as foreign and being able to do something about it of itself. Well, immunotherapy is being developed and it's in its infancy. There's a study that we're running where we take a patient's blood cells, we turn the blood cells into a cell which recognises all the things that are foreign and bad. We feed the tumour to the cells and we re-inject that tumour as a vaccine, hoping that that vaccine will tell the rest of the body, say, come on, here I am, come and get me, come and get anything that looks like this. And the immune system will work to the body's advantage. Well, in the lab, the amount of antibody, the amount of cell killing of tumours goes up with virtually every single patient. It looks fantastic. But what happens in patients? You actually get an early increase in tumour size because the tumour is inflamed to start with, so it gets bigger. You get signs of inflammation around it, and later you may or may not get stabilisation and shrinkage of some disease. But how do we define success? We're sitting there in the clinic with a family in front of us, we've given the vaccine, and we say, hey, the tumour's bigger. I think this is a good result. Now, how is that going to go down? It's a completely different set of outcome data that we have to get used to as doctors and families have to get used to as an expectation. Now, so far, we've concentrated on traditional outcomes, treatments that makes the tumour smaller and treatment that prolongs life. And clearly, those are really important outcomes. But in developing chemotherapy and in developing multidisciplinary treatments for brain tumours, they're not the only outcomes. See what you think. Is this a success? It's an 8-year-old child who has a stable optic tract tumour on an MRI scan. It was first diagnosed when the child was under 1 year of age. They've had one course of chemotherapy, they've had an operation, they haven't had radiotherapy. Who would say that was a success? Hands up. Quite a lot of hands up. Okay, this is the same child. 8 years old, morbidly obese, unable to control his appetite, hyperactive, uncontrolled rages, almost blind, hearing problems from chemotherapy, multiple permanent hormonal problems, almost no short-term memory, no chance of independent living in the future. Same child. Who thinks it's a success now? No hands. So I mentioned that we're looking at late effects of our studies, but so far those studies simply parallel the clinical results. We say these were the late effects. How do we use these results to alter therapy? Is there a formula for what percentage decrease in the chance of cure we would accept for a given percentage better quality of life outcome? I don't know of one. And who would decide this? Is it doctors and nurses that do it? Is it families that do it? Is it past patients that do it? We need to work out these metrics if we're going to develop treatment rationally for the future. And also, we need to look at palliative care. Sadly, still more than 30% of children will die of their disease. When is enough curative therapy actually enough? What do we understand about what families really want at this phase? Do they want to keep on going with new drug after new drug after new drug trial aimed at cure? Or do they actually want to optimise symptom control and be involved in studies looking at that? Actually, what do we learn from new drug studies in children who've had multiple other therapies? What can we actually ascertain about the efficacy of those drugs? We need to understand that if we're going to plan our studies of chemotherapy better. It's a beautiful Picasso painting. I think it's very moving, I think. So hopefully I've showed you that in order to do any of these things, collaborative trials are key. Here's Rex's timber haulage. He started fetching the occasional stick and he built up the business from there. I mean, it's only by putting our individual sticks as individual clinicians, individual hospitals, individual countries into the sort of font of knowledge in a coordinated way that we're going to improve the development of clinical trials and the outcome of children with tumours. And I'd just like to thank the CCLG personally, really, for generations of research and energy and support. So as a paediatric oncologist, I was brought up by the CCLG, and I'd like to thank you all for your attention as well. Thank you.